So I'm really happy to have everyone here today. My name is Rakesh, and I'm the Provincial Coordinator for Research here at the Alzheimer's Society of BC. Today's presentation is part of our research webinar series, where we host researchers to talk about their work. At the Society, our mission is to ensure people affected by dementia are not alone, by educating, mobilising a broader community of care around them and supporting valuable research into the disease and people living with it. This includes making research more accessible and connecting research to more people. So in that spirit today, we're happy to be hosting a local researcher, Dr. Shelley Canning. Dr. Canning is an associate professor in nursing at the University of Fraser Valley. She's the director of the university's Centre for Education and Research on Ageing and is currently the president of the Gerontological Nurses Association of British Columbia. Dr. Canning is also a 2022 Alzheimer's Society Research Programme grant recipient for her project exploring dementia-friendly approaches for cancer patients living with dementia. And we'll be hearing more on the plans for this project today. So now I'm going to turn off the slides and hand over to Dr. Canning. Over to you,
Great.
Shelley.
Thank you so much, Rakesh. So thank you so much, Lori and Rakesh, and thank you to everybody who's taken the time to join me this afternoon and give me an opportunity to share a little bit more about what I've been doing. I'd like to start by acknowledging where I am. So the University of the Fraser Valley is about 80 kilometers east of Vancouver. If you don't know the Fraser Valley well, we've got campuses in Abbotsford and Chilliwack and Mission. And I'm actually right now in my home office. And that's located on Stalo, unceded Stalo territory. And specifically, I live and work in the lands of the Matsqui and the Sumas First Nations. And I am very privileged to work and live in this area, and I acknowledge that privilege. So as Rakesh indicated, I am a nurse and I teach in the nursing program at the university. So I teach primarily first-year students. And my background in nursing has been a mix of community health nursing as well as oncology nursing as a nurse at BC Cancer. And over the years, I've realized that when you work in the community and when you work in cancer care, you work with a lot of older people. And as I moved into the academic world, teaching at the university and engaging in research, I've done a lot more with working in the area of aging, but more specifically looking at the experiences of people who live with dementia. So that's kind of where I've traveled as a nurse. So the study that Rakesh introduced, we are very thankful on the research team to have funding from the Alzheimer's Society of Canada. And our two partners are the Centre for Education of Research on Aging, of which I'm the director, and BC Cancer. And I've listed all the folks on our research team on the slide here, and I think some of you will recognize Dr. Lillian Hung. She's a close friend and a good colleague, so we're delighted to have her on our team. Dr. Michael McKenzie, Genevieve St. Martin, Jagbir Kaur are all clinicians at BC Cancer. We've got some nursing students working with us as research assistants, and we're really delighted to have a couple of patient partners. So Lynn Jackson has come on the research team as a person who lives with both dementia and has experienced cancer. And then Sarah McCourtoff is a caregiver for someone who's living with cancer and dementia. So their voices are rounding out our team, I think, in a really fulsome way. So this is the way I think I'll run my talk today. I wanted to talk a little bit about the project beginnings, where the idea came from. I'll give some background to the study and share a little bit about how we've designed it, so what we're going to do, what our next steps are, and then finish with a bit of an opportunity for you to get involved in something that I think is really exciting. The research grant was awarded, I think it was May, and I've been working really hard with the team to get ethical approval in two institutions, the university and BC Cancer, and secure kind of our setting and really consolidate the team. And that's taken us well into the fall. So unfortunately, I don't have study findings to share yet. So I'm going to be really focused more on the beginnings of the project and where we are. So the project beginnings really come from my passions as a clinician and as a researcher. As a clinician, I have worked with both people who live with dementia and people who are cancer patients. And so being able to bring them together in this project kind of brings me full circle, really, as a nurse. And what I know about those two populations is that individually, they're both very complex experiences for us to navigate either the cancer journey or the dementia journey. And for people who are navigating those two diagnoses at the same time, there's tremendous challenges for the person themselves, for the caregivers who walk alongside them, and for people like me, the nurses, the physicians, the technicians that try to meet their needs. One of the things that makes it all so challenging is negative perceptions or negative attitudes. And the slide that I've got up here is a slide that I start a lot of my presentations with, and it's a slide that I use over and over in my nursing classes. And I really believe that the ways we understand older people and people that live with dementia is just fundamental to the way that we treat them. I see it on a daily basis in practice. I hear it when I hear my students talk. And a lot of my work in the last years has been focused on how do we change perceptions around dementia and around aging. And I bring age and dementia together, not because everyone who lives with dementia is older, but because it is a lot of people who live with dementia are older, and there's a lot of similarities and connections and intersections. The term ageism is a much older term than dementiaism, and dementiaism isn't always used a lot even in the dementia literature, but certainly most of us know what that means. And when I use it in my classes or I use it in presentations, I think it kind of shocks people a bit, and they sit up and think, well, what is that? I understand ageism. I understand what it means to have discriminatory, stereotyping types of attitudes, but how does that fit with dementia? And the penny usually drops once we start talking about it, and I think about the ways that people with dementia are so clearly stereotyped in terms of disabilities, particularly being less capable of understanding, and it rolls out less capable of much. And along with that then comes, at its very worst, a real focus on, in healthcare, a focus on diagnosis or disease or care tasks, and very little on the actual person and their experience. And that's really at the core of person-centered care, this idea that we go beyond the disease and we actually consider the person and their experience in our care. But we know, certainly I know as a care provider, and I'm sure many of you who are either care providers, caregivers, or individuals living with cancer or dementia who are in contact with care providers, we all know, I think, that while there's pockets of excellent care, there's a lot of places where the care is not optimum, and we're not really doing best practice. I see these negative attitudes within the healthcare system, and again, this is kind of the background that brought me to ask the question at the center of the study that I will talk about in just a minute. But what we know in healthcare is that older patients are seen in very negative ways, and it's difficult because the healthcare system has limited resources. When we look at older people being described as bed blockers, in truth, there are a limited number of beds. And so when there are no more to be found and we end up with backlogs in other areas of the hospital, of course, it is problematic. But it's the way we go about it. And there's structural issues within healthcare that I think we can look at and perhaps move things in a different way. And certainly if we begin with language and attitudes that are more positive and not focused on some of these negatives, it creates a much more positive healthcare environment. When it comes to patients who are actually living with dementia, often the narrative is even more troubling, and they're seen in terms of being so time consuming, real concerns about wandering, about people being agitated or aggressive or angry or confused. And the difficulty is that, well, sometimes people living with dementia experience a real challenge with our healthcare environment. So often the care providers don't seem to know what to do and how to address someone, for example, who wants to leave a unit, who's not sure why they're disoriented, and they're anxious to be somewhere else. Instead of taking a dementia-friendly lens, care providers often feel unsure of what to do and then begin to be quite prescriptive. And a lot of that really comes from the fact that we don't have a great educational foundation. Care providers have very limited education in terms of both age and dementia. And on a hierarchy of places to work, working with older people or working with people living with dementia are not really seen as the top draws. So when I teach my nursing students and I talk about the care of older people, I talk a lot about what it is like, what we need to think about when we're caring for people who live with dementia. All they can think about is working in emergency or working in ICU or working in maternity. So it's very hard to, even when you have the time to do specific education, it's very hard to get students to really see that this is going to be a big part of their careers. And in truth, it will be. We know the numbers are large, and we know that whether you're a healthcare provider in the community or acute care, the bulk of the people that we care for are older, and within that group, there's an increasingly large group of people who also live with dementia. So these negative attitudes have really driven, again, my teaching, my clinical understanding when I take students into a clinical area, as well as my research projects. We know that when staff view patients in a negative way, there are negative outcomes. There are negative physical and mental health outcomes. Often, issues within these populations are kind of minimized or brushed over as if it's just normal, it's what we expect. So instead of investigating the same ways that we might with a younger patient or a patient who's not living with dementia, we just brush it off as, oh, it's just because they have dementia, it's just because they're older. We see slower recoveries, and with that slower recovery, we're very anxious still to use that quick trajectory to get people in, to have treatment done, and then to ship them along. And it just simply doesn't work well. The experiences with COVID-19 and long-term care really highlighted, really highlighted the issues that we see with an older population, and especially that population who are living with dementia in long-term care. So it's very problematic, but there are things that we can do to make it much better. So my concern in my questions for this study really came out of thinking about, well, what about cancer care? I know from my background as a cancer nurse that it is a really challenging, it's a really challenging environment for any patient to go into, but even more challenging for patients who are also living with a diagnosis of dementia. We know that age is the main risk factor for most cancers and most dementias. And then with the population growth, with our demographic picture changing, that number is increasing. So this group of this particular population of patients, cancer patients who also live with dementia, we're going to be seeing that group more and more. At the same time, there's very limited resources, very limited research that's been done. And most of that work, I've done some literature review as I got myself geared up to write the proposal for this study. And really the vast majority of it has been done in the UK and been done in Europe. And what they found is a real inequity of patient outcomes for if you're comparing a person living with cancer with a person living with cancer and dementia. So the person who also has dementia on top of their cancer diagnosis has a real decreased likelihood of receiving screening and staging of cancer. And when we stage cancers, we determine whether it's found at a very early stage or a much later stage. And there's a real difference in our outcomes depending on whether cancer is diagnosed early or diagnosed late. At a much later stage, there are less options that we can offer, less treatments that would be appropriate, and then less success in terms of good outcomes. So that's a real problem. We see less curative treatment offered, and we even see less hospice care offered, which is interesting to me. So there's a study that showed patients who live with cancer, typically most hospice patients do have a diagnosis of cancer, although it's not a given. You can have another diagnosis and access hospice care, but the vast majority of patients within hospice are cancer patients. But those patients who also have dementia are seen to have less access to hospice care. So again, all of that inequity in terms of screening and staging and treatments leads to diagnoses that are at later stages and much poorer prognoses. The literature tells us that the caregivers have significant challenges, and one of the areas that they're really challenged in is the decision-making process. And when someone is diagnosed with cancer, there are multiple places along the trajectory where decisions might get made. So decisions around typically having a treatment and then considering what the impact might be on quality of life. For myself, my mom actually had a diagnosis of cancer a few years ago, and so I have that, recent experience as a caregiver where my mom was an older person and she was given options. If you have this treatment, there are these side effects and these negative side effects that might happen. So are you willing to take this risk to have some potential positive outcomes of a treatment, knowing that there may be some potential negative outcomes? So it was difficult for her to make those decisions. She wasn't living with dementia, but she was an older person who was struggling to make some of those really big decisions. And I think at all ages, those are hard decisions to make. But if you layer on some of the complexity of dementia, it becomes even more challenging. So what caregivers for patients who had both diagnoses found was that they had a real weight with trying to balance, making these kinds of potentially life extending decisions around treatment options, or the potential for a negative quality of life. The caregivers were also really involved with a lot of arranging appointments and communicating information. So cancer care involves a lot of appointments, follow-up appointments, lab work, and things are done on a very tight schedule, because if you've had one treatment, then there'll be a limited length of time before your next treatment has to happen, so that you get the most benefit out of the treatments. And so navigating that in between time with communicating information, getting lab work done, arranging for the next appointment, transportation can be an issue, and then side effects. Many cancer treatments, there are side effects. And so when the person living with cancer and dementia goes home after a treatment, the caregiver is monitoring and managing what would be often some very complex side effects. So the role of the caregiver was difficult. And then the care providers, the literature tells us that it's challenging for them. And while I spoke a little bit early on about how many care providers don't have a strong knowledge base or foundation for providing good care to either older people or people who live with dementia, it's not that care providers want to provide poor care, but they either don't have the education and foundation that they need, or there's a lot of structural issues within the healthcare world that make it difficult for them. So some of the things that the cancer care providers are faced with is it's difficult to have a dementia diagnosis communicated between the different areas of the cancer care system. So those diagnoses are often not shared well. The primary focus in a cancer care system is cancer. So those cancer diagnoses take precedence over any other chronic health issues or any other diagnoses. So it was frequent that care providers didn't actually know a person was also living with dementia. That wasn't flagged well in their charts. It's challenging for care providers to provide care for the complexity and the acuity of many of these patients, again, because they've had their diagnoses later, at a later stage of cancer. They're also faced, the care providers, with some of these ethical dilemmas. So when they're providing an opportunity for a patient to make a decision, knowing that the treatment decision-making may not be able to be made easily by the person who's living with dementia, depending on what their stage of dementia is, depending on how well they're still able to make decisions for themselves. So that's a difficult place for a care provider when you want the patient to make the decision, and you know that it's difficult for them. The cancer care pathways are inflexible. I mentioned a few minutes ago about the challenge with having things have to be timed very particularly in cancer care. So there's not many ways that we can change appointments or shift things around because of other things that are happening in our lives. If any of you have been in a cancer care center, it's most of the cancer care that we have here is outpatient care. There are medical units on most of the large hospitals, acute care settings, that do specialize in having some cancer care done there, but the bulk of our cancer care is done as outpatients, where people come in and out of the BC cancer sites. And those are busy places, multiple floors. Sometimes you go up to the third floor for something, then you're down to the basement for something else. You're up to the second floor, pharmacies on the first floor. So there's a lot to navigate just in terms of the physical environment. And waiting times can be long. So for patients that come in and they're waiting to go from the third floor to the second floor, back up to the third floor, you can be sitting for long periods of time, not quite sure what's going on in the queue, but waiting for your turn. So cancer care is complex. It begins with diagnosis and treatment. And there are three main treatment modalities that we use. So often there can be a surgical procedure. It might be a surgical a biopsy to help confirm a diagnosis, or it might in fact be a surgical procedure. For example, sometimes with breast cancer, you'll see a lumpectomy or maybe a full mastectomy. So a fairly major surgery that will happen first, often first. And then that might be followed up with radiation. That might be followed up with a form of chemotherapy or immunotherapy. So radiation is typically done, it's typically done in a series where the total dose of radiation is divided up over a series of appointments. So you may go once a day for 5 days a week, once a day from Monday to Friday for 3 weeks. And so there's your kind of inflexible care path, because your treatments will have to happen on those particular days. You can't take a week off typically, or a month off, so your radiation will be prescribed. And then chemotherapy, the same type of thing with chemotherapy. You'll have your appointments booked. You'll come in as an outpatient. Often it's an intravenous that would be started, and you would have your chemotherapy that way. Some chemotherapy is oral, so you could be at home and take those oral medications. But the side effects of both of those treatments, radiation and chemotherapy, can be really challenging. And another piece of what we do in cancer care is also palliative care. So nurses and the care providers there are well versed in good symptom management and end of life care. So on to my study. So my question was, how do we do a really good job of looking after these patients? How do we make sure that cancer care is dementia friendly? So when we have a person who's diagnosed with cancer who also lives with dementia, how can we best meet their needs and take a dementia-friendly lens or a person-centered lens to the type of care that gets provided? So that really was the impetus for the grant writing and the study that we're conducting now over the next 3 years. And the research questions are on the screen here. So we're asking, what are the cancer care experiences of patients who also live with dementia, their caregivers, and their care providers? And I think I made the case with, that bit of a look through what's already been done in some of the studies that have been conducted in Britain and Europe, that it's everybody who we need to look at, the patients, the folks that are their caregivers and supports, and also the care providers that are trying to do the best care they can. So out of that, we'll hopefully find an answer to the second question, which is what strategies and initiatives would support a dementia-friendly approach to care? And then what would be the impact of a dementia-friendly education module for care providers? Because we believe that in increasing the amount of education that cancer care providers have and putting that focus on the idea of dementia-friendly care, that will be the key to actually having dementia-friendly cancer care. So the research is going to be conducted, our study, over 3 years. We're in the first year right now, and we're really focused on phase 1, and that is exploring the experiences of the patients with both diagnoses, their caregivers, and the care providers. And we're going to do that through a series of individual interviews, and we're also going to conduct some participant observation sessions. So those will be, it's a little bit different. It provides a really rich, I think, understanding of the person's subjective experience as they come into the cancer agency or the BC Cancer site. One of the researchers would join the patient and their caregiver there and wait with them as they wait and watch and observe as they go through their either follow-up appointments, it might be a treatment, but just navigating the physical environment, navigating the appointments. So getting a little bit of a sense of really what is it like to be a person trying to go through that system. So that will be phase 1. And then as we analyze all of the information that we get from our interviews and our observations, then from that, we're going to develop some education, and we're going to pilot it with the care providers in Abbotsford site, Surrey site, and Vancouver site, and then come up with some recommendations for practice that can be shared with BC Cancer. And for those of you who haven't had any experience or know much about BC Cancer is the province-wide health, it's the province-wide providers of all things cancer care. So they provide the full spectrum of cancer care. The BC Cancer is involved in prevention and screening. They run the mammography clinics. There's certainly the focus on treatment, diagnosis, and again, as I said, on palliative and supportive care. BC Cancer are big funders of research and education as well. And BC Cancer sits under the Provincial Health Services Authority. So it's part of a provincial-wide authority rather than a regional approach. So all cancer care in the province comes out of that one the one entity. And there are 6 different sites across the province. So BC Cancer, when I started as a new nurse, was mainly everything was in Vancouver at the Vancouver site and a smaller site in Victoria. But it's grown a lot since then. So there are now sites in Abbotsford, Kelowna, Prince George, Surrey. I'm sorry, I misspelt it. As well as the original sites in Vancouver and Victoria. So I know there's quite a few folks here from the interior, so you may or may not have had something to do with some of the interior sites. And the stage we're at right now is recruiting our participants. So we're looking for, and there may be someone who's interested in participating in our study who's on the webinar right now. So we're looking for 10 cancer patients who are also living with dementia. And it can be any type of cancer, any type of dementia. And we're looking for 10 caregivers who are caregivers for patients, cancer patients also living with dementia. And we'd love to get kind of a range of experiences. So if we have folks from a more rural settings, as opposed to having everybody from the Lower Mainland in the larger urban settings. So we'd like to just get as much variation and diversity as we can. Diversity with ethnicities, diversity with genders. We've got a pool of participants that we're recruiting from cancer care providers. Again, we'd like to get a mix of care providers from different cancer sites. and also different disciplines. So physicians, technicians, social workers, pharmacists, could be there's any number of different care providers with different roles that they play in BC Cancer. So we'd like to have a real mix there. So the inclusion criteria is that you would have provided care over the past 5 years to someone who lives with, a cancer patient who is also living with dementia. And then we have also we got nurses. So we know the close role that nurses play in care. So we're recruiting a cohort of 15 cancer care nurses. So for everyone out there, my email is there. It actually should be all one line. I'm sorry about that, but I'm happy to answer questions in the moment, and also I would love anybody to send me an email.
Okay, fantastic. So I can talk through the couple of questions. And so we've had one question from Suzanne. So Suzanne is the caregiver for her husband, who's in his 4th year of vascular dementia. He went through sudden cancer surgery in June to remove his jawbone and grafted bone from his leg. And Suzanne mentions that you need to care for both the patient and the caregiver, and that's really important. But sometimes the caregiver can be forgotten, and there's not so much support for the caregiver. So, are you aware of any respite for caregivers of people with both cancer and dementia?
Suzanne, I don't think this group has been really considered at all, which is from the bit that I have been able to do in the last year, connecting with people and talking at BC Cancer. This is quite a novel study. So I would say no, not as far as I know. There certainly are caregiver support groups that are organized through BC Cancer, but I don't believe there would be anything that would be unique to you.
Thanks there, Shelley. And so if people would like to participate in this study, the best thing would be to email you on so we've put your email address in the chat box, and
Yeah.
that's the best way to contact you, because
Yes.
we've had a few people interested, which
Oh,
is
excellent. So if you're interested, you can email me and I will either respond right away, or I might pass it on to the research coordinator, Nicole Percival, who's one of the team, and she's kind of coordinating all the interviews and observation sessions that will come up. So I'm delighted if people are interested. And if you just have any question, of course, you can email me.
Thanks. And I'll put my email address in the chat box too. So if you have any questions regarding anything about the presentation today, we can try our best to answer them, or I can forward things to Shelley as well. That wouldn't be a problem at all. And so now might be a good time while people might
Sorry,
be.
I'm just going to jump in. I scrolled way up and I see there's one question that someone put in quite early on, Shelley, that you may be able to answer. And I do apologize, the person who just raised their hand. The nature of this session means we cannot unmute people. So please, our only way of interacting with you is through the chat box. So apologies if you're not able to access the chat. Anyway, the question is that someone has their father has been diagnosed with bladder cancer and has dementia, and they're wondering, now obviously this seems to be more of a diagnostic question, and so likely is kind of outside. She's wondering if he can forego radiation treatments as he gets very anxious. The oncologists don't recommend either surgery or chemo. And she says, we struggle with him on a daily basis as we never know if he is just crying wolf and not sure if he does actually have back pain. Any suggestions or recommendations would be appreciated. And I thought that might be something that you could address, Shelley.
So, yeah, the first part of that around how difficult it is to decide if someone who is anxious is able to tolerate a treatment. I think it's really critical that the caregivers communicate to the care providers, to the physician who's going to be planning the treatment, or the technicians that are there, be really clear about the diagnosis, that your father has dementia and that these are the ways it presents itself. So maybe there are times where he's really good, good in the sense that he can manage things much more easily and feel much less anxious in stressful situations. Maybe there are things that trigger his anxiety or trigger his stress that we could do in the environment to make it a bit better for him, so that maybe he could tolerate treatment if we were able to make a few little changes. Sometimes we're not able to make a lot of changes, but I think when you communicate to the care team, and if you have some real specific examples or even some requests that this would really make a difference for my father or my partner or my wife, it helps us a lot. And we do try to, I guarantee people would be trying hard to make that work for you. So the more we know, the better. I guess that's that part. In terms of pain, pain management, that is a real skill, and usually oncology nurses are excellent at pain management. And without knowing your dad or seeing him or knowing the system, it's very hard for me to say too much, other than if there's a nurse, or if there's a connection that you've got with the care team who could perhaps give you some pointers about what to be looking for in terms of either verbal or nonverbal indicators of pain, that might help. But I would turn to the care team. I'm hoping that you're linked up well with somebody, and don't be shy to say what it is you're not sure about, or that you think, you're not sure whether he's experiencing pain, or maybe it's something else that's going on. I hope that answered.
Thanks, Shelley. We have another question from Miriam. So Miriam's question is about how to make it easier for patients with both dementia and living with cancer in a special care unit. Has there been a thought about making a cancer unit mobile, knowing that with advanced dementia, it's impossible to leave the unit?
Oh. So this is someone who's living in long-term care in a locked unit. That's my guess.
Yeah, I'm not sure. Miriam, yes, that's correct.
The difficulty is that cancer treatments are so highly specialized that they can only be given in certain settings. And the 6 BC cancer sites, for example, radiation is only offered there. It's such a highly specialized intervention that we do, and only qualified technicians and medical physicists. There's a huge team behind the scenes for every single radiation treatment that is given. There are many people who plan it out, and it has to be in a physical environment where there are thick walls and protections against radiation leaking out, if you will. So unless the person can physically go to one of the sites, they wouldn't be able to get the radiation treatment. Chemotherapy treatments are more easily given. Certainly an oral chemo treatment would be, and intravenous chemo treatments can be given in many hospital settings, although some of the more complex regimens are only given within the cancer care sites. So I really hadn't actually thought about that, that particular group. So I don't know really what to recommend if there really is no way that he would be safe to go to. I think I would be exploring every avenue to see if there was a treatment that would possibly have a really good effect. I would want to know what can we do so that we can bring him to the treatment. Without knowing again him, it's hard for me to say, but I would be pulling out all the stops. If there's something positive to be gained by treatment, is there any way we can get him there so that he could tolerate it?
Thanks, Shelley. And Miriam does just write another comment, just talking about how it's important, you need to weigh the trauma and the benefit. Would this be a factor too? Because it's shortening the lifespan at the same time. And so there's lots of things to consider here.
And that's the stress on the caregiver. Those are such monumental decisions and that you make, and nothing is, you do have to make your best decision based on everything that's before you. And the care team, they will tell you, they'll give you some numbers often, some statistics, but they will do their very best to let you know what is to be gained. And if there's nothing significant to be gained, they won't be encouraging treatment for sure.
Thanks. And we have one recommendation from Suzanne for a book, Daily Comforts for Caregivers by Pat Simples.
Thank you, Suzanne.
And now, Shelley, might be a good time to change topics, just looking at the time that we've got 9 minutes left. So perhaps you can talk about your other project,
Sure.
and then we can field some questions if there's any questions about that too.
Okay. So I am also involved in a lot of intergenerational research. And as I said at the very beginning, one of my motivators is around dispelling some of the negative attitudes and the myths and misconceptions that surround dementia. And along with one of my colleagues, we've developed a course for UFV students to take within the visual arts department. So my partner Candice is an artist and a professor of art at UFV. And we did a big project last year, which turned out to be really successful. And so what we're looking at doing is finding a way to partner students with people who live with dementia so that some of those assumptions and stereotypes get challenged and dispelled. I get to teach nursing students about dementia all the time. But the rest of the university, those students, they don't often get an opportunity. So we have a course that's going to start in January, and it will be an opportunity for people who are living with dementia in the community to collaborate with the university students in the creation of a piece of art. And at the end of the course, we'll have an exhibition showing at the art gallery at the university. And what we're hoping for the students, as I've got on the slide here, is that they're going to learn about the experiences of living with dementia, because they're going to work with and meet and talk to and form a relationship with someone who lives with dementia. I also am going to come into the class as a nurse and talk a little bit about some of the pieces of dementia that might help them to have a better foundation and get rid of some of the myths and misconceptions. And for the community collaborators, the people who live with dementia, I'm hoping it'll be a really positive, exciting opportunity to work with a younger person. You may not all have lots of opportunities to have an intergenerational connection. You don't have to be an artist at all. This is about really forming a relationship, giving suggestions back and forth with the students about how the creation, whatever the art project, the piece of art at the end of the course is going to look like. So the students, this is a 4-credit course. The students will begin with making a piece, a small art piece without meeting you. All they're going to get is your name, your age, how long you've lived with dementia, and maybe some information about something that's important to you. So they're going to create kind of a blind piece of art, and then they're going to have the chance to meet you and engage with you and talk about what they did, and then together come up with an idea for a second art project for them to do. And you'll be able to engage with them in that process. And so we're envisioning that there would be maybe 3 or 4 times that you would meet over the semester between February and March. If you are in the Abbotsford area in the Fraser Valley, you could perhaps meet in person, or we can meet over Zoom. So right now we have, I think, 12 to 15 students, and they're not all art students. Some of them are students that just want this opportunity, and then others are art students. So I think it's going to be a lovely mix. So again, if you're interested in that, please email me and I'll connect with you. I can talk to you over the phone too if you like, and give a little more information.
Thanks, Shelley. And Laurie has so kindly put Dr. Canning's email address in the chat box again. So if you are interested in learning more about either of the projects, the email address is just there. This art project sounds so very interesting and so unique as well. So this will be starting in February, between February and March. It'll be.
Yeah, the actual course will start in January, but again, the students are going to make a blind, they're going to make a project with very little information about their community partner. And my assumption is that some of their assumptions are going to show up in the first piece. And then after they get to know you, there'll be a much richer, full piece that they're able to create with you because they know you.
Well,
and you're more than your, you're more than your diagnosis, and that's the key.
Well, we'd be very keen to find out more about once this is done, and we hope you'd come back again and share the results and share some pictures of some of the work that was done as well, and some of the things that you found out. So I'd like to thank Dr. Canning for sharing this information about 2 very different projects today.
Yeah.
And I would like to thank everyone for attending this webinar. Thank you, everybody, and I hope you have a wonderful rest of your day.
Thanks so much.
Thank you.